All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. I hope you had a great weekend. It seems like the Facebook side may not have connected well to the live chat. So today, probably mostly YouTube audience and the Periscope. So hopefully you had, excuse me, hopefully you had a great weekend. Let's start a discussion. What I wanted to do was respond to the remaining Twitter questions that we have now. It is third working day that we have kept them waiting. So if you allow me, let me get rid of those questions first. Let me get done with those questions first, and then I'll come back to the live audience and see what are the questions here. Yeah, I hope that is okay. So let's start. So yeah, that is a good question. Although today Facebook is not connected, I do not know why not. So if I do again to go live, it might work. Okay, so Facebook is not connecting today for some reason. So yeah, tell me which country are you from if you are watching and if you are present here. Okay, so this is drbeen.com. Then the questions that I wanted to continue on from is the Vic RV's question here, and then we'll continue moving upwards. These are the links that are related to the question here on Twitter, and we'll go over some of this data and information as well. Interestingly, majority of the questions left are about ivermectin. So this might become a tiny bit of a segment for ivermectin. So the first question here from Vic RV is there a concern with Parkinson's patients taking ivermectin, potential to crossing the blood-brain barrier? Can you explain the following study with regard to ivermectin and PD? And I think there is another part here. Is natural immunity more comprehensive? So let's look at this part first. Ivermectin, blood-brain barrier, and this specific study. So let's look at it. So here is what we are looking at in this study. The study says that there is a P-glycoprotein. There is a protein called P-glycoprotein. This P-glycoprotein or P-gp is something that is of interest right now, and that is what I'm going to discuss that here on Wikipedia. And once again, I know people criticize me for using Wikipedia. I usually go and look at the references, and I make sure that from my books as well, that things that are rhyming, that is what I use. So this is fine here, this information. So P-glycoprotein, it is also called P-gp or P-gp and so on. So we're going to talk about that. In this discussion, keep this in mind as well, that Rhodamine 123 is a dye that is water soluble. So for example, if you want to understand that how is my blood-brain barrier working, what you can do is you can inject the dye, and then you can keep taking pictures of me to see when the dye enters the blood-brain barrier or if it does not. So this dye is used as a tracing material for active substances to move in or outside the cell or from one compartment to another, many times in vitro, and that is how it is used. So now let's see what the discussion is about here in this study. In this study, what they're saying is they're actually not talking about ivermectin specifically. What they're talking about here is Parkinson's. And they are saying that we know that there are certain pesticides that can cross blood-brain barrier and cause or be related to Parkinson's. We are not fully sure what exactly causes Parkinson's. So there are so many relations. For example, in Parkinson's patients, the exposure to pesticide is observed, for example. So here they're saying that we wanted to understand how the neurotoxic substances, specifically pesticides, may be entering the brain, and what is that mechanism. In that, They have used ivermectin as a pesticide as well and seen that is this something that also uses PGP. So really, please realize this. This study is not about ivermectin. This study is about the understanding of P-glycoprotein's role in allowing neurotransmitters to stay in the brain tissue and cause damage. Sorry, not neurotransmitters, pesticides, substances that can cause this damage. For example, the pesticides that they looked at are diazinon. So if you see here, this is diazinon, dieldrin, endosulfan, and then ivermectin, manib, MPP, and rotenone. So these are the pesticides that they wanted to understand that how are they affecting the brain. Now, why is the PGP there? What happens is this PGP, P-glycoprotein, if you see here in this diagram, imagine that this is a cell, not necessarily just a brain cell, some cell. And we will discuss which cells we're talking about. In these cells, there is a machine or a pump. So when I used to live in Massachusetts, one day, one winter, there was so much snow that some houses and their basements got flooded. And what they had done was they had taken pumps to pull the water out of the basement and then throw it out. This PGP protein acts like that. It is a protein that is attached to the cell membrane, and inside the cell, it has a portion here. So if you see this part, it has a part on which ATP attaches. ATP. ATP is the currency in a cell, correct? So when a cell functions or parts of the cell function, most of the time they use adenosine triphosphate or ATP. That is the money in our cells. So of course, when PGP is going to function, it is going to ask for money as well. It is not going to function for free. So for that money, it asks ATP. It says, all right, give me ATP. I will use that energy and I will operate. I will function. I will function like a pump, and I would take harmful substances that are inside the cell and throw them out. Acts like a pump that would take the things that are, for example, the water that has accumulated inside the basement and pump it out. Similarly here, PGP does not really care for the water. What it does is it connects with substances like pesticides or other toxic substances that are produced by viruses or bacteria or fungi. So normally we say toxic substances that have come in. So if you see here, these substances are neurotoxic pesticide. There is one more here. 1 second. I want to talk about these. There is a specific name for these toxic substances, although now I cannot find it. So don't worry about it. So toxic substances that are present inside the cell. The function of the PGP is to use energy and then throw them out. Now think about it for a second. Imagine this is a neuron. This is a brain tissue cell, or this is a blood-brain barrier cell. If some neurotoxic pesticide goes in, crosses the blood-brain barrier, and enters the cell, the PGP, we expect from the PGP to pick up that neurotoxin and throw it out again. So the study that we are seeing was done for various pesticides to see if all of these pesticides are thrown out or removed by PGP. That is the study. The short of the answer from the study is, number one, ivermectin itself is not related to Parkinson's, number one. Number two, they saw that some pesticides, when they entered the cell, PGP was able to throw them out. And then some pesticides, when these entered the cell, PGP was not able to throw them out. They saw that when ivermectin entered the cell, so there is no role of PGP here. Ivermectin entered the cell because of, let's say, a compromised blood-brain barrier. Then it did bind with the PGP, but PGP did not move and throw it out. So when an enzyme binds with some substance, we say that that substance is a substrate for the enzyme. Right? So imagine if I am an enzyme and if I wear a hat, that hat will be called a substrate for me. It is something I can work with. Similarly, when ivermectin enters a cell, now remember, normally ivermectin does not cross blood-brain barrier. They had done this study in vitro where they forced the ivermectin to enter the cell. So this is not normal study we're talking about. When the ivermectin enters the cell, it does connect with PGP, but somehow PGP does not throw it out. And there are some pesticides that the PGP can throw them all out, and there are some pesticides that it does not throw them at all out. So the conclusion of the study was that we know that if ivermectin enters the brain, it can cause damage. We also see it connecting with PGP, but we do not see PGP doing anything and removing it. So the ivermectin's mechanism seems to be more complex than trying to figure out if PGP can help. That is the basic gist of it. So let me first answer the question here from Rick RV. So the question is there a concern with Parkinson's patient taking ivermectin? So the answer is no, because number one, if you see here in the study, ivermectin itself is not related to Parkinson's. So here, our data demonstrate that these substances are not inhibited by PGP. We identified these further substances that need further understanding. And then there is one more question here, and that is, in ivermectin part, they have talked about it, that it is not related to Parkinson's. So number one, ivermectin, even if it crosses the blood-brain barrier, it does not do anything to Parkinson's. And if somebody has Parkinson's, it does not have an additional capability. The brain does not have any further issues that allows the ivermectin in. So the short of the answer is that yes, it is okay for a Parkinson's patient to take ivermectin. So here, yeah, this is what I was looking for. Although ivermectin has not been associated with Parkinson's, it is a pesticide that has been reported to be a PGP substrate and was used as a comparator. They said we used it just to see how does it work. So this is the study. Then if we continue on, Vic RV has one more question. Is natural immunity more comprehensive and safer against immune escape? Does infection offer more protection than vaccination for the young? Should vaccination for the healthy young even be a priority, especially if vaccination does not prevent spread? So the shorter answer is vaccines are not actually, these vaccines for SARS-CoV-2 are not even recommended for young. They are 16 years and above or 18 years and above. Second part of your question, is the actual infection better than vaccine? Of course. If I get infected today with the actual virus, my response is going to be much better than a vaccine's response. Vaccine is a tiny amount. Infection is going to spread in my lungs and throat and everywhere and really kick the immune system. The problem is that the actual infection can become so dangerous in some people that they can die. Because of that, we don't want the actual infection to come in. Now, because young children handle it well, the vaccination is not given in young children anyways. I know that Pfizer has been testing their vaccination from 12 years and old, but they do not have sufficient data. Liliana says, wondering if the administration of vaccines are causing more COVID patient cases and therefore deaths as well. Any thoughts? So important thing here, and that is that the vaccine itself. So let's say if this is a cell, the cell, if it has the virus SARS-CoV-2 in it, then the virus is going to do a lots of damage in terms of making many, many more new viruses that are going to destroy this cell. Then they're going to come out, and then they're going to go to the next cell and destroy that cell, and they would just keep going on destruction. A vaccine does not do that. Vaccine is a measured quantity of messenger RNA, for example. If it is, let's say, 1 million molecules of the RNA, then we'll make maybe 1 million, 10 million, 100 million spike proteins, but not like the virus, which would make billions of copies. And then once messenger RNA has been used up for some time, maybe half an hour, one day, then it is destroyed. The virus can actually escape all of this and keep going from one cell to the next one and the next one. In that process, virus actually also suppresses those enzymes and the defensive systems that are going to protect our cells. And so remember, the interferon is reduced. So because of that, the disease caused by virus can never be caused by spike protein. The only thing you can get with spike protein is that at the site of injection, you might get soreness, you might get pain, you might feel myalgia. Myalgia is not exactly the respiratory damage. It is the feeling of pain in the muscles and fatigue. And that is the immune response. But that immune response is not a cytokine type response. The issue with vaccines that we are seeing are the allergic reactions, which are in some cases leading to death. And I'm saying that in the air quotes because I haven't yet studied or researched that part, so I may be wrong. But we know that allergic reaction, anaphylactoid reactions are occurring. So to answer your question, if the administration of vaccine is causing the patients of COVID, no, that is not possible. Continuing, Buddha GV says, what's the correct way to take ivermectin on empty stomach or with heavy meal? So ivermectin is preferred with meal. Heavy or not, it is preferred with meal. Its bioavailability is better with meal. Although if you take it on empty stomach, it works fine as well. It is absorbed too, but its availability is better when you take it with food. And I have a link for that in the description as well. So the description previous to this video, so the last video has a link in it which shows that why ivermectin is actually useful to take with food. So hope that answers that question. COVID-LT, unfortunately, long hauler. While there may be no easy way to detect viral persistence, any good heuristics we can use, short bursts of 40 to 50 milligrams. So I believe I answered this question in the last video. Can vitamin D intake possibly have detrimental effect on long haulers' haywire immune system? Vitamin D's function is to regulate the immune system responses. So ideally, vitamin D should not cause overwhelming response. Vitamin D should actually balance out the response. So it should actually be better. What ivermectin dosage do you recommend for long haulers? So once again, I cannot give any prescription to anyone who is listening to it. For my own patients, fortunately, I do not have any long haulers within my own patient group. And I think the reason for that is that I have been just attacking this disease so early and so aggressively. You know, sometimes my patients actually become sick of me because I'm just calling them and sending them texts and saying, okay, how are you feeling now? And tell me your oxygen saturation. That I am actually more in a hurry than they are. But the benefit of that is that less people become long haulers. Actually, I had a few long haulers where I started the steroid courses and they recovered. In one case, the person after 2 months still developed the symptoms and I gave him one more course of steroid and he recovered from there. So I have never used ivermectin separately on a long hauler to actually see what happens. My recommendation is going to be the same, that just like prophylaxis, that day one, ivermectin, 150 microgram per kilogram body weight, then day 3, then wait for a month, then 1-3 as well. I give ivermectin prophylactically every week to my patients. So the short of the answer is there is actually no known dose for this. Avox Coffee Bean, this is my same question. So let's see the question above. Norman, I'm so sorry to the folks here on the live side. I will be with you very shortly. Just a couple of more questions. Norman Kelly says, given the distinction between infection, disease, would a reinfected vaccinated person with full immunity shed as much virus as totally asymptomatic person with COVID? Would an infected person on ivermectin possibly shed less virus than a vaccinated person due to mechanism of action? So the good questions. Let's take them one by one. So the first part, would a vaccinated person with full immunity shed as much virus as a totally asymptomatic person with COVID? Let's look at that together. We know that when the vaccine is given, the IgM will be produced in the beginning, then IgG will be produced, that would continue for months, and then IgA will be produced as well, that would go and protect our mucous surfaces. So let's say if this is mouth, the IgA is going to be protecting the mucous surfaces here, or the wet surfaces, correct? So now let's say this person becomes infected. So from outside, some viruses enter and they go into this mucous surface. That is where the viruses have to go to then catch a cell and then infect the cell, then increase in number in there. However, in this person, the IgA is going to block the virus from entering the cell in large numbers. It's just going to make it coat it. Now, when that person coughs or talks or laughs or sneezes, that person is going to eject the virus again. But this time when the virus comes out, it is coated with IgA. Not only that, it may actually be coated by other things as well, because the cells were trying to kill it. So this virus may not be viable when it is shed to cause infection. So this is the technical part of it. From the vaccine companies' trials data, they say clearly we have no idea. They say we do not know if the shedding is reduced. They say we do not know shedding happens, and so on. Now let's look at the asymptomatic person. In an asymptomatic person, what happens is that we think that either their immune system is not even bothered about the virus. That's one possibility. In case of children, we feel that their cells do not have sufficient ACE2 receptors, one. Secondly, we feel that their innate arm is stronger and it takes care of the virus right at that level. That means when a child is going to cough or talk when he is infectious, he would actually eject in the beginning viruses that are not coated by IgA yet, because it is their immune system, that is innate part of the immune system, that is taking care of it. Number one. Number two, they may not have enough ACE2 enzymes on their cell that the virus has to go in there and replicate and come out. So this person can shed more. Now let's talk about one more situation with this person, and that is that they are a carrier. We do not know yet that there are carrier states, although long haulers may have a carrier state. If they are a carrier, that means their immune system is not bothered. It doesn't care for the virus. It just at a very low level responds to it and doesn't really kill it, doesn't really control it. If that is the case, then there will be some IgA present here, but the virus will be so much that when it is getting out, it is going to be with or without IgA. And so it can be more contagious. So asymptomatic person. Now there is one more situation with the asymptomatic, and that is a person who just became infected and will develop symptoms in 5 days, but it is the day 4 or day 3 where their immune system is still not active and they still do not have symptoms, and they are asymptomatic, but the virus is going rampant. The virus is just dividing and increasing in number. I shouldn't use the term divide, but increase in number, and eventually it is ejecting as well. They are very contagious. They're asymptomatic and very contagious. So that means somebody who is asymptomatic can be of various kind, and based on the kind, they may be more contagious to less contagious. On the other hand, if a person is immune, as you said, totally immune with vaccine, then their shedded virus should actually be less harmful, but the data is not available. So officially the answer is we don't know. Hopefully that answers that question. Avox says, this is my same question, so I won't add mine to the main thread. If vaccinated person is hosting virus, are they as contagious as an unvaccinated one would be? My guess is no. So Avox, I just responded to that. Your guess is correct. Vic RV, have you heard of painful, unexplained bruising? Look like bruise due to a trauma, but no recollection of trauma post-COVID. Yes, so we have heard of the COVID toes, for example, where they become the tips, fingertips, and the toes become bruised and blue. There are bruising on the skin as well. So that is because of the blood vessel, small blood vessel damage by COVID and by cytokines, which causes the blood vessels to become swollen and damaged, and they leak a little bit and the blood comes out, and that is the bruise. Of course, it would go through its phases of red color and then purplish and then brown, blue, and then black, and then resolved. So yes, it happens. Now, this is another question here. Jem says, I found this study, the antipyretic drug Ivermectin is a novel FXR ligand. So she has this question. It is a very interesting question. The question is, so Jem says, do you know if taking Ivermectin lowers blood glucose? That is a question, an important question. I am taking it as a prophylaxis. Jem, you're lucky that you got it for prophylaxis. Send some to me as well. And I noticed my blood sugar is much lower. Not sure if it's also because I've been trying to diet some. So so she has done a study as well. That study is here. And it's a very interesting study. So let me first give you the short answer. Yes, ivermectin can lower blood glucose levels. Now the question is how? And let me just explain that. Jem will have to have a reward for asking a great question. So here we are. So this cell here, this box-like thing here in the middle, is a liver cell. It is a hepatocyte, liver cell. The liver has a very interesting behavior that the blood from our GIT, which is rich in the nutrition or nutrients that we ate. So when we eat something that is digested, it goes into the blood. That blood, all of that blood from GIT has to go to liver. It cannot bypass the liver. Liver will pick up any toxic substances, any poisons, any drugs, anything, and either activate them or deactivate them. So liver is like the gatekeeper of what is coming in from the GIT. It doesn't trust us that we would eat the right things. So it sits right in the first gate and says, okay, tell me, what did you eat and what have you brought in the body? I'm going to try to detoxify that and then let it go in the body. Now here, I have a liver cell, a hepatocyte. Check it out how I drew this. Do you see these little blocks here with their shadows and everything? So this is a hepatocyte. On one side of the hepatocyte, imagine a row of houses that are the cells, and on each side of the row of the houses is a road. So, for example, if this is a row of houses, there is a road here and there is a road on the other side. So I've taken one house and I am discussing that. And so one side is this side here, and then the other side is this side. Now what happens is the function of hepatocytes is, or liver cells is, they pick up the nutrients from the blood that is coming in from the GIT. They take that from the blood. Then they act on that, on those nutrients. They filter them out, they detoxify them, they activate them. If there is some glucose related things, they store them as glucose. If there are proteins, they break them down into smaller proteins. If there is cholesterol and lipids, they work on them. So they pick them up, they work on them, and then it is possible that the resultant, after the processing, the result is pushed back in the blood, for example, glucose, or some of that is pushed into the bile to go back in the GIT. So on one end, they have a bile system, and these cells can take nutrients from the blood from the other end, process that, and then push them in the bile. Or they can take the nutrients from the blood, process them, and put them back in the blood. So hopefully this much is clear. Now let's see the role of ivermectin here with the liver. Here is our ivermectin hero. Ivermectin binds with an enzyme in the cell called FXR. So FXR, if I go here, Farnesoid X Receptor. It is an enzyme called a receptor. And there is some more data about that here. There is some more data about some enzymes here and some more data here. So I'm going to go back here for a second. And here. Ivermectin binds with the FXR. Now the function of FXR, if ivermectin is not bound to it, what is the general function of FXR? Function of FXR is that as our hepatocyte, as our liver cells, they make bile. They prepare bile. And as they make it, that bile can actually attack or bind to the FXR receptor, to this thing. And then sensing their level, the FXR would then go in the nucleus and then tell the nucleus to stop making more bile. So we call it a negative feedback mechanism. It is a control mechanism where when the bile is made from cholesterol, and if we have too much bile, the bile needs to be reduced, further production needs to be reduced, and for that, when bile binds with the FXR, FXR goes into the nucleus and tells it to stop making bile. Good. FXR also can bind with two more or affect two more enzymes. One enzyme is called PEPCK, phosphophenol pyruvate carboxykinase. I remember when I was in medical school, we used to kind of cram this enzyme's name because it is an important enzyme. We'll talk about it. Phosphophenol pyruvate carboxykinase. And then the other enzyme is G6Pase, glucose 6 phosphatase. These are two more enzymes. So what is the function of them? Imagine I have taken food in the morning, breakfast. Within 2 hours, the nutrients from the food are taken up from the GIT into the blood, into the liver, and then to the rest of the body. About 2 hours later, the nutrients that came in, especially sugar and glucose that came in, has been sent into the cells. And now we do not have enough glucose. That is called a fasting state. For our body, that is a fasting state. We are used to going from breakfast to lunch. But after 2 hours of a meal, our body is kind of entering a fasting state. In that state, body needs glucose to continue to work. So what it does is it tells the liver cells to say, hey guys, can you make glucose from other things in the body and give me glucose till this person, my body, my owner, eats again. So when we are making glucose for our need, then these two enzymes, phosphophenol pyruvate carboxykinase and glucose 6-phosphatase, are used to make glucose from pyruvate, from existing substances in the body. It is seen that FXR enzyme or receptor can actually influence the function of these two guys and suppress them. Now think about it with me for a second. This is a complex topic. I love diabetes and its methods and mechanisms. I've done I think 17 lectures discussion of diabetes. So think about it with me for a second. I took my breakfast. 2 hours later, whatever I had taken that has been used up, body does not have enough glucose. Body is asking for more glucose to continue to function. And then these two enzymes and some more enzymes are being used to produce glucose. It is called gluconeogenesis, new glucose production. These two enzymes are used in that process. If we don't let these two enzymes function, then we cannot produce new glucose. And now let's connect the dots. If somebody has a higher glucose level or somebody is diabetic and they have glucose already sitting in their blood, their body is in a fasting state because insulin cannot push the glucose in the cells. So cells are crying and making a lots of hoopla saying, I need glucose. They don't know that there is so much glucose in the blood because insulin is not helping the glucose get into the cell. The cell is saying, I don't have glucose. So then cell continue to send messages to liver to say, give me more glucose. And liver continues to make these enzymes activated to say, guys, make more glucose. So not only are glucose that came from outside is sitting in the blood, liver is also making glucose and pumping it in the blood. And these two enzymes are working. It is in this research that you sent me, Jem, they show that this receptor can actually suppress these two enzymes and reduce new glucose production, hence reducing the level of glucose in the blood. So that means ivermectin can actually be used. And again, this is not an approved drug for that, but it can be used as an anti-diabetic as well. And this study is not in humans, it is in rats. So please know that what I'm saying here is all a study, not a prescription to say take ivermectin for blood glucose. But Jem, if you say that your blood glucose levels are reduced after ivermectin, then yes, ivermectin has this function. So now the question is, how does ivermectin do this? Here is how it does it. Ivermectin enters our liver cells and binds with FXR receptor and modulates it and regulates it. When that receptor is regulated, it in turn causes the regulation of these two enzymes. When these two are regulated, suppressed here, they reduce their function and more glucose, new glucose in the body from liver is not formed. And that is how ivermectin reduces the blood glucose levels. Beautiful question. And I love drawing these little enzymes here as well. Just to give you some more data on this one. Here, there are some steps. So this is for the medicos out there. Here are the steps for glucose production or glycolysis, or not production, breakdown of glucose, sorry. And then glucose production or gluconeogenesis. So if you come down this way, this is the glycolysis. And if you go up this way, this is gluconeogenesis. So we know that when we take glucose, We have hexokinase or glucose 6 phosphate that puts a phosphate on the glucose at the position 6, correct? Then we continue on in the glycolysis and we make fructose 6 phosphate. From there, we make fructose 1,6 bisphosphate. I remember cramming these steps when I used to be in medical school. And this is the phosphofructokinase enzyme 1. Then phosphophenol pyruvate is converted to pyruvate, which will then be fed into the Cori cycle, not Cori, Krebs cycle, and that is pyruvate kinase. This is glycolysis, that is breakdown of glucose. Now look at this side. This is making new glucose, gluconeogenesis. And look at the ivermectin's role here. Look, here is pyruvate. When we are in fasting state and we want to make glucose, pyruvate is used up to make oxaloacetate. And that is pyruvate carboxylase enzyme that does it. Oxaloacetate is then converted into phosphophenol pyruvate by phosphophenol pyruvate carboxykinase. This enzyme is blocked by FXR under the influence of ivermectin. So we cannot make new glucose. So glucose levels will go down. That is one area where ivermectin acts. The other areas here, when this step continues, eventually we get glucose 6 phosphate. In the muscles, I hope you know this, medicos here. In the muscle, glucose 6 phosphate does not become glucose. Muscles are selfish. I always used to tell my students that muscle look like a fish and they are selfish. They don't want to give their glucose to the rest of the body. They make it, but they keep it. Because they know if I have to walk and talk, I need my muscles to work. So muscles never give glucose away. They can take it, they don't give it back. So muscles would not convert glucose 6 phosphate to glucose and then release it in the blood. But liver and other cells can do this. What they'll do is they'll take glucose 6 phosphate, they'll use this enzyme glucose 6 phosphatase. This enzyme is missing in muscles and they'll make glucose. This glucose will be then released in the blood, and that is how the glucose levels go up. Now, this is the second step that ivermectin blocks through FXR receptor. So when ivermectin binds with FXR, FXR blocks these two enzymes. So this part of making new glucose is blocked or suppressed or downregulated, and that is how the new glucose is reduced. That is how ivermectin can reduce the blood glucose levels. I hope that that works. This is a interesting and complex phenomena, but I love these mechanisms, so it is interesting for me to discuss them too. So back here. So Jem, that is the answer. Dallas for Life says, question, what can you infer from experiencing little to no side effects on the second dose of the Pfizer vaccine? I am 53 and feel like my immune system is very strong, yet beyond some mild arm soreness, felt nothing, whereas some of my peers got pretty run down. So it is not necessary that the strength of immune system is directly proportional to the side effects. If your immune system has learned very quickly for how to work with the vaccine and has not activated a lot of inflammatory responses, then you would not have a lot of inflammation. On the other hand, in some folks, it is possible that inflammatory systems become more active, that is, prostaglandin system becomes more active. So this is true that in immunosuppressed, when you have infection or when you give vaccines, they have less milder reaction, and that is because of less immune system response. But in a healthy person's case, for example, yours, where there is no, you said that your immune system is robust, so there is no immunosuppression. In this case, your system just handled it well and did not overreact to it, which is fine, totally fine. That doesn't mean your immune system doesn't know how to work with it. It just knows it, and it's not even bothered. Dallas for Life 44. Question, I read where Moderna's leadership feels strongly that immunity with their vaccine will last for years. Can we assume the same with Pfizer since their format is the same? Yes. And I have been saying this since March, April, that the infection will give us immunity for 2-3 years. Similarly, vaccine will also give us immunity for longer time, at least 2-3 years. That is the behavior of our body with SARS-CoV-1 and MERS-CoV. And with SARS-CoV-2, now that we are almost a year in it, there are many studies that are showing the immunity up to 8 or 9 months. So technically, from a concept point of view, from previous experience point of view, I actually once showed in the books that the immunity from SARS-CoV-1 continues for 2-3 years. So I expect the same here as well. Jumping bean. Given that it is unlikely most of us will not have access to vaccine before July, shouldn't we continue to focus on prophylaxis? Absolutely. I feel the bridge from here to vaccinated is ivermectin, vitamin D, melatonin. So these things that we've been talking about, ivermectin being the most important part. And it is unfortunate. I think it is criminal. I think it is negligent. I think it is lack of incompetence. I think it is indifference on the medical leadership's point to not allow ivermectin. Second part, I believe the first line of defense is masks. Yes. Shouldn't scientists spend more time studying how effective commonly used masks are? So there are so many studies already. The problem is not the studies with the masks. The problem is the anti-maskers have brought in a lot of disinformation. And then we, the cool beans here, and I know that in our gathering, we have anti-vaxxers and anti-maskers. I have discussed some of these studies in the past as well. I like to believe things that we can at least try to explain them or observe them. If, let's say, you do not have a mechanism of action in your mind, but you do something and there is a clear answer and you see it, then that is an observation. For masks, there are many studies that showed their effectiveness by observation and their effectiveness by technical experiments. But unfortunately, there are folks who just keep muddying the water as well. So to your question, yes, these studies, mass studies, there are tons of studies. And number two, yes, we should do prophylaxis. Dallas for Life 44. Question, once vaccinated, I have read that taking an Nsaid for soreness can impact the efficacy of antibody production. Is this true? So very good question. Let me give you a very, very quick answer. The short answer is not significantly. Now, a little longer answer is that when you give a vaccine, and it causes a cell to express that vaccine, and it causes the immune system to respond to it and release the cytokines. Now, these cytokines will in turn cause fever and those things. However, when the damage would occur here, for example, when the natural killer cell is going to come in to contact with the vaccinated cell, which is expressing the spike proteins and saying, look what I got these little flowers, which are spike proteins. Natural killer cell is going to say, you bad cell, you are infected, I'm going to kill you. So when that happens, that broken cell pieces would irritate other cells, plus within their own broken pieces, prostaglandins will start becoming activated. That activation would cause the feeling of, so that prostaglandins would create, will cause pain, swelling, and redness. Right? Now, let's say you have taken some antipyretic. You have taken acetaminophen or ibuprofen or something. The function of these drugs is to actually reduce the action here of prostaglandins. These drugs do not really reduce the activation of immune system. Because of that, the vaccine's effectiveness is not changed by the antipyretics. Now, just like I was talking about some scientists muddying the water, there was a study that came out somewhere in, I believe, 2009 timeframe, where somebody said, you know what, I think I have observed that when you give antipyretics and then you give vaccine, the vaccine is not as effective. And they said, you know what, parents do not give children antipyretics when you bring them for vaccine. Some really cruel research workers who didn't want the children to not feel pain. Since then, this topic has been going on. So there is a study that I wanted to show you. Here is that study. This is a study where they have actually tried to really figure out that is this really possible that if we give NSAIDs or painkillers or antipyretics that can somehow reduce the immune system's function. And here, there, if you look at this side, this is the B cells proliferation, B cell increasing in number. And then they say, if you see here, NSAIDs or the painkillers, they might reduce some proliferation of the B cell. But that has never been observed to be significant. There was one study that proposed that. That study muddied the water so much. And again, science is like that you can bring in your muddying the water part as well. And then the rest of the community's response is to go figure out or keep responding to it. So since then, this thing comes up. So if you see here, the answer to the question of whether antipyretic analgesics have a clinically significant impact on vaccine response has significant public health implication. Although generating a great deal of interest in this topic, the 2009 Pre-Muller study did not answer the question because the acetaminophen-associated antibody blunting that was observed following vaccination still resulted in protective antibody levels. So what they're saying is that even that study said, well, there is some reduction in antibody levels, but antibody levels were still sufficient to protect the body. So they said, what's the fun of having this information? Additionally, their follow-up study showed a robust antibody response following the booster dose. So when the booster is given, the immune system still became very strong. So the study included in our report and so on. So no, the short answer is no. Tom Pool, I believe this is the last one, and then I'll come to the live side. I have totally ignored the live side today. I hope you don't mind it because I was ignoring the Twitter side before. Tom Pool, if the UK fills their hospitals, what home care protocols should be considered by folks who get early symptoms? Can you self-triage, oxygen, anti-inflammation, inhibit viral replication, support T-cell, etc.? So, Tom, this is a very similar question to what I had been asked in Twitter, that what should we do in UK? Vitamin D levels should be good. If sunlight is not sufficient or if it is cold and you're bundled up, keep your vitamin D levels up. And to keep them up, high dose vitamin D with vitamin K2, with magnesium, with calcium. That is one. Second is quercetin and zinc is important too. Third, of course, mask, physical distancing, stay inside and all that. For natural killer cells, to make them robust and more, please do light exercises and please stay stress-free or try to be stress-free, because when the stress is less, we have less stress hormones. For example, adrenaline and steroids. The stress hormones are known to suppress natural killer cells. And natural killer cells are very important to fight with SARS-CoV-2. Kids have them in abundance and kids don't even care for SARS-CoV-2. So natural killer cell by number one, staying happy and relaxed, and number two, doing light exercises. Then, of course, ivermectins and those things if we can get them. Finally, to your question of triage, yes, of course, that is what they've left us to, that, hey, stay at home and just wait till you have low oxygen levels. So one should have oximeter at home. I do not know in UK you can get it over the counter or not. Here you can. Oximeter should be there so that you continue to see your oxygen levels. Of course, thermometer should be there so you can look at your temperature. Of course, you should be aware of the symptoms, which I think all of us are now aware of it. Anti-inflammatory are fine. But I think the vitamins and supplements that we have discussed, for example, CoQ10 and glutathione, vitamin Bs, they are more important than anti-inflammatory because these things modulate the immune system and prepares it to fight better. So that is the answer. I hope things become better soon. Uh, now on the life side, how are things here? So Cher says, I've added NSE along with the rest of the Mass Plus. I wonder why Dr. Marek does not suggest. Dr. Marek, we actually, Cher had asked this question from him when he was part of one of our discussions. And he had said that he thought there were so many other, what are these, reactive oxygen species neutralizing substances that he didn't think that NSE was also needed. I always give NSE, I give CoQ10, I give glutathione. My way of working is that I go overboard, especially with the diseases that I'm afraid of. For example, SARS-CoV-2 is a scary disease. If it doesn't kill a person, there is a 40% chance that it makes them long haulers. That is not a good state to be in. So I just give whatever I can, which I know from mechanism point of view can work. But that is what Dr. Marek's response was. So BLDG Maker says, can you discuss the liver bile ivermectin thing if you've had a gallbladder removed? So gallbladder removal does not prevent liver from doing its normal function of making liver. So the mechanism that I discussed is still applicable. Wayne says, what dosage of ivermectin do you recommend for day one? I've heard 0.2 to 0.6 milligram per kilogram. So considering where I stand normally, the therapeutic dose of ivermectin's range is 150 to 200 microgram per kilogram. I have never given ivermectin outside of this range. Wow, oximeter in Australia cost $100. It's like $10, $15 here. I hope these oximeters work fine here. You're welcome. Yes, so M. Gregory, if that happens, then yeah, please don't take it. You're correct, Franz. We just don't take a chance with this thing. So Brown Hilda says bamlanivimab and others. I think bamlanivimab is great as well. The thing is, just give it early. So YT user says, YouTube user, ivermectin has a drug interaction with the blood thinners warfarin. However, can ivermectin be used with the newer NOAC blood thinners? I think they can be, but the point is that what is the total risk of the blood? What is the quantity? What is the levels? So this is something that should not be used without talking with your doctor, because severe bleeding can cause hemorrhages and strokes. So first get the labs, then talk with the doctor. Yoga each day, yes. And thank you very much for the super chats. I have become so used to the coffees and super chats. You guys have spoiled me. So I'm just trying to see if there are more questions. Wayne says, Dr. Bean, I'm just in awe of your artistic skills. Will you be auctioning off your drawings? So the funny thing is that all of my paintings that I've made till to date, these are all taken by my friends. Nobody leaves the paintings back with me. So I love doing this, But usually whenever somebody visits us and they see some painting, they say, you can make one more, and they take it. Franz, thank you very much. So this open forum continued on for 3 days, but I wanted to make sure that I can try to answer everybody's questions. So Jim, I wanna clarify this point. Did I hear Dr. Mobeen say that the people infected with COVID-19 have about an 8-9 month immunity? People infected with the COVID should have an immunity for 2 to 3 years, healthy people. Problem is, we haven't been with this disease for 2-3 years, so we can only speculate and not say by data. So because we have been with this disease now for a year, we can give more data, more solid data, and answer for at least a year. So the latest study that we have seen so far has been chasing people and taking their antibody levels for 8 months, and they say thumbs up. Now that is SARS-CoV-2 data, only available till 8 months. As the months keep going, we'll keep getting more and more data available from studies. Now, if I look back at SARS-CoV-1 and MERS-CoV, and if I look back at the books that I had actually referred, I had done a video about WHO's incompetence. In that video, I had taken up books from here and shown the book pages where they talked about coronaviruses and their immunity and their spread and everything. So I had shown some studies as well that showed that with SARS-CoV-1, antibody production continued for 2 years and then declined for 1 more year. So till 3 years, there was robust antibody response. There is one more study that shows the cytotoxic T cell response to SARS-CoV continues for 10 years. So ideally, in theory or from previous experience, we should expect 2 to 3 years. From current data of this virus, we have data up to 8 months. So that is what, Jim, I was saying. Thank you very much for more super chats. Eric, yeah, sometimes tinnitus just continues. It's a difficult thing. I'm just looking through the chat that I had ignored and see if I can answer any questions here. Chuck Becker says, I love this club of caring, witty folks who are whip smart. Absolutely. They have made me smart by asking smart questions too. And what I'm really proud of is that the cool beans, this club that we have, this tribe that we have, we are educated. Whatever our decisions are, want to have vaccine, don't want to have vaccine, want to have a mask, don't want to have a mask, whatever our decisions are, there is still a lots of information available underneath that we have been discussing. This is, I think, including your questions sessions, I think we are above 260 topics now. So Wayne, whenever melatonin does that, reduce the dose. Cool. So today I know that the Facebook folks are missing out because my technical system did not connect with Facebook. You're very welcome, Barbara. So Simple Garden says, SARS-CoV-1 showed resolution to long hauler issues after 18-24 months. Can we expect the same? Yes. Yes. And the reason is very simple. There is a technical reason. The reason is that our body stops responding to this virus after 2 years to 3 years. That's what I just talked about, the immunity. So because of that, any further bothering of the immune system would go away. So this long hauling state would not live forever like in hepatitis, these things happen. Absolutely smart beans, yes. So I hope this is what we have for today. Please do me a favor. So there are a couple of questions more here. Brown Hilda says, what do you think about, so we talked about that. There is one more question from Davis. Can ivermectin reduce the production of glucose reducing the production of glucose be problematic if I'm working out while fasting? So the thing that is not clear is how much reduction. So do me a favor, if you can actually monitor your glucose for a day or so when you're taking ivermectin, that would actually tell us how much reduction. Ivermectin is not an anti-diabetic drug. So if it was that potent, we will know it. So Jem, maybe you can also help us to see how lower the blood glucose levels go. And Davis, Davis, if you can actually monitor it and then see how much effect it is giving you. So with this, thank you very much, everyone. There is a, number one, please like, subscribe, and share. Number two, there is a link in the description of this video for buying me coffees and catnips for Luffy. Many people have actually been buying catnips for Luffy. And then there is another link in there that is for, if you like my work, you can support my work as well. So thank you very much. I'll see you tomorrow.